All right, if you have a known calcaneal fracture, are you obligated to get any spinous imaging, or can you rule it out clinically?
I think that you probably ought to be able to do it clinically, but I'd have a very low threshold for ordering LS films, very low.
And that follows then, would lumbosacral be enough, or are you obligated to check thoracic? If they have no clinical pain in that area, is a lumbosacral enough?
I think a lumbosacral is enough if they have no pain of higher than that.
I wouldn't do it at all if there's a clinical examination that suggests that there's no evidence of pain, limitation of motion, can you bend over and touch your knees kind of thing. It would be kind of silly. You're giving a lot of radiation to when a lumbar spine is taken to the little gonads down there. So, you know, it's certainly not a standard of care by any stretch of the imagination. It's just something that you should think about.
So just make sure your documentation
Yes.
reflects that you thoroughly did a lumbosacral exam. There is no pain there. That should be standard of care appropriate.
Right, so people with the quote-unquote poor glide ratio, they jumped off something, bilateral calcaneal fractures, you want to make sure that your exam reflects you've checked the knees, the LS spine. You probably want to dip UA on them because renal injuries occur with this as well. And so the axial skeleton and the GU systems ought to be looked at.
Thank you.
Very good. Over on the right, sir.
Yeah, my question is regarding the nitroglycerin drip treatment of congestive heart failure. It's been my experience in practice that usually the IV Lasix stat is prescribed, gives them very rapid relief. I'm not familiar with what kind of dosing you use. Is the dosing of the nitro drip the same as you'd use in an acute coronary syndrome, or is the dosing more rapid or different?
Well, the dosing is, I think, basically one that gets titrated to the blood pressure kind of thing. You basically would like to get that, obviously, 160 over 110 blood pressure down, and it's the number that gets it there. It's a little different than maybe an acute coronary syndrome where you're trying to increase perfusion to these
pain.
But so the marker is getting that blood pressure down. And the nuance about furosemide causing a little vasoconstriction is true, whether it's of clinical significance or not. It's certainly easier to get a bolus of Lasix into somebody rather than going through all the rigmarole of getting your drip, which you will be getting, but it's not going to get done as quickly as...
I think that the more important thing to remember with regard to the Lasix, and the reason people always say lead with nitrates and follow with Lasix, that's the traditional teaching because of this vasoconstriction and other things. The other thing to remember is that when you see someone with overt failure, 70% or 75% of the time they're fluid overloaded. So they need Lasix to get rid of that fluid overload. But remember that means that 25% of the time they're in failure, they are not fluid overloaded. If they're euvolemic or in hypovolemic failure and you give them Lasix as a reflex, that 25% of the patients are going to get worse with Lasix.
Yeah, we talked
because
about
they weren't
those
fluid overloaded.
Those cases, the flash pulmonary edemas, where it's really primarily a sudden cardiac problem.
And the other major cause of hypovolemic failure is pneumonia. In Canada, when they look at Canadians have access to primary care, they take their medicines, generally speaking, that's just the way they are. And in their large series looking at CHF, the most common cause of a CHS exacerbation in their group was pneumonia, where the pneumonia worsened their cardiac performance. And with that pneumonia, of course, comes fever, insensible losses, poor PO intake because they're vomiting. So pneumonia with CHF is another situation in which they're often hypovolemic failure. And Lasix will make them worse.
All right, very good. Thank you. Over on the left.
I have a question about burns. In a patient with a pretty painful second-degree burn, and they have a sulfa allergy and a bunch of pain medication allergies, virtually everything that we could offer them, what do you suggest for topical treatment and pain management?
Oh, that's a hard one. Well, certainly sylvadine is not the only thing you can use. You can use some of the bio dressings are impregnated with silver as well, which is the antibacterial part of it. You can also use. I mean, if you had to resort to using bacitracin or one of those, you can. They're not quite as they're a little bit more messy, but you could use those too. Pain management wise, if you have someone who can't take opiates, that's a problem. It's not. I mean, there's other things that you can go with. You can certainly go with NSAIDs and other traditional acetaminophen routes of going those directions. But it's it's really painful, and certainly opiates are the standard of care for the treatment of pain.
The other thing is some of the grandma treatments again. So for small area burns, there's no question that cool tea bags make an excellent compress.
The Earl Grey?
What?
Earl Grey.
Yeah, I like Earl Grey. I like to drink it first and then use it. So cool tea bags and things like that, which provide a nice conduction of coolness to it, will help.
Yeah.
I think it's amazing that Sylvadine is still around, to tell you the truth. There are so many better things that people can be using, particularly in these adhesive burn dressings that you leave on and you don't change every day. You leave them on for a week kind of thing. They do get a little soupy, but they're made to work by creating an environment, and they also have these antibacterial properties. Sylvadine is a mess.
Yeah.
These silver impregnated gloves and dressings, they're pricey, but boy, are they nice, because you don't have to change dressings every. These burns come back and you're trying to pick this dressing out of this thing. The patient's in pain. That's why those silver impregnated gloves and dressings are wonderful, because you don't take them off.
Would there be any benefit of using like a LMX cream or topical lidocaine?
I think Alamax is, if you're really cornered for pain on a second-degree burn, I don't have a problem with that.
Okay.
It really depends on how big it is, because
Yep.
there's the potential for
Lidocaine toxicity.
Yeah.
As I mentioned with the road rash when I was talking about the maximum numbers, you can get there.
Okay. Thank you.
Thank you. Over here on the right. Yes, ma'am.
Hi, my question is for Dr. S. I was curious. I live in an area of the South where every other yard has like 3 pit bulls in it, so we get a lot of dog bites in our ER. Some people have already gotten the rabies vaccine and they come back with another dog bite a year or 2 later. How long is that rabies vaccine good for? Or do they need, if there's concern, will they need like the vaccine and the IG again?
That's a good question. Actually, I don't know how long the vaccine covers you for. Anyone know?
I don't know about the length, but what they recommend is they've already been vaccinated, they don't need the rig again. You just need day 0 and day 3 of the vaccine. But I'm not sure the time frame
Yeah.
between
Yeah,
doses.
If you've had the
It's
vaccine,
been 2 or 3
yeah.
years. I think they're still covered. But
More importantly is the fact, and I don't know what the data is at your animal control in your state, but I can tell you in California, there hasn't been a dog bite case of rabies in over 30 years.
Yeah.
So we do not give rabies prophylaxis for dog bites, period.
And the best thing would be is just observation, because if it's a domesticated animal, they can observe it for the 10 days. Or
Yeah.
Yeah, we, in where we work, we report all those to the Department of Public Health, and they follow up. Do we know the dog's owner? Can they verify that the dog was vaccinated? And in some of those cases, there's not a need for a rabies prophylaxis.
So I guess the ratio of people who get rabies treatment for dog bites, I bet you it's like 50 to 1.
It's very low.
Yeah.
Thanks.
Thank you. Over on the left, sir.
My question involves the use of the troponin in the admission of a patient or the evaluation of a patient with congestive heart failure. So if you have a patient presenting with clearly a CHF exacerbation and as part of your work, but not a high suspicion for MI, and known congestive heart failure, nothing on the EKG or the history that really makes you think it's an MI, and then you get back a mildly elevated troponin. And then in that setting, I feel like a lot of people are then diagnosed, and maybe the patient's tachycardic as part of their congestive heart failure presentation. So the diagnosis then is this a small MI versus just a CHF exacerbation with a little troponin leak? I wonder if you'd comment on that question, because it
I
seems
think
to have
the
implications.
scenario you're
for the-
describing is one of a troponin leak. I mean, they make it sound like you need to duct tape the pipes or something, but this concept, particularly with the newer, highly sensitive or ultra-sensitive troponins, you're going to get positives just with PSVT. You're going to get positives in CHF with strain. So I think you have to now put on your thinking cap with that troponin. The picture you described where they're not having a lot of chest pain, they've had failure before, they've got a bump, I think that's an acute CHF exacerbation. I see no need to invoke a new diagnosis of acute coronary syndrome
And that's-
in that setting.
That's where a delta trope or a trending of the trope can be really helpful, to see which direction it's going.
There's a paper we just did for the abstracts this past week in which it takes the position that not all patients who have exacerbations of congestive heart failure need to be in the hospital, and that there are three groups. Basically, one group that has low-risk comorbidities who rapidly responds to treatment, that in the right setting, they can go home. There's another group who responds less quickly, but they are responding and maybe have more risk factors. They can go to observation. They may be there for 4 or 5 hours or 6 hours. And then there's a third group that basically requires hospitalization. But this is an attempt to deal with this idea of readmissions of these cases. The other thing that...
And to deal with the epidemic of CHF, right? If you talk to CMS, they believe that we're seeing sort of an epidemic, a wave of congestive heart failure, because we've had so many people now who've been revascularized, who've been stented, who are living longer with their heart disease. It used to be people had the good sense to drop dead of a heart attack, and then they didn't stay in the population with heart failure for another 10 years. But now we have far more survivors, plus we are an aging population, and there are a lot of people who are getting CHF in their 7th decade, 8th decade, and so we have huge numbers of CHF, and we're just beginning to parse out the new manifestations and the new epidemiology of this disease. Some of them are relatively minor, can be dealt with. Some of them are having a bad event. They're having a new coronary syndrome event, and we're beginning to parse it out. But that epidemiology has been a little bit of a moving target that reflects sort of the changing nature of who has CHF, which is very different now than it was 30 years ago.
It's not just about the money. A lot of people, it's no fun to be in the hospital. And one of the other papers we did in the same issue, which was done a week ago, looked at people who were discharged from a hospital and looked at a lot of them wound up going back to the hospital, not for the reason that they were admitted the first time, but hospitals are basically, you get deconditioned in the hospital. They had one statistic that said 50% of the patients in this Medicare survey were malnourished as a result of their hospitalization. They basically are on new medicines. There's a litany of reasons when you come out of a hospital, you're not in such hot shape, independent of the reason you went in.
Right, so they're bouncing back for their low back pain and their urinary tract infections, not just for the fact that their failure's not better.
So it's not a readmission for CHF, it's a readmission for some other problem. So the idea, right now, it's a knee-jerk, all CHFers get admitted, but the fact of the matter is that they think that they can tease out the ones who will get benefit by going home versus a hospital is bad for you. The length of stay for CHF, in the slides that I showed you, 6 days. That's a long time.
Thank you.
Thank you. Over on the right, sir.
Yes, concerning shock states and especially with septic shock, comparing lactate levels and a base excess, is there truly a need for doing a lactate level, and how much does that offer you as far as decision
Yeah, I
making?
think the lactate's again, I talked about this wide array of non-specific biochemical markers that we're now playing the game with, and the list includes the white count, the SED rate, the CRP, the base deficit, the lactate, the procalcitonin, the acidosis,
BNP?
and well, no, not so much the BNP. But anyway, they're all in there. So the question is, which is better? The one thing about the lactate that has been shown that has not been shown for the base deficit is that a lactate in the patients who aren't as sick recovers pretty quickly. So, for example, in a patient who seizes, who's not sick, but didn't breathe very well and developed lactic acidosis, their lactate may clear very quickly within an hour. And so this lactate has a little bit more long-term predictive ability than the base deficit does. So if I was picking between lactate and base deficit, I personally would pick lactate. If you were talking to a trauma surgeon, they're deeply in love with base deficit. If you were to talk to an intensivist, they prefer the lactate. Is there strong science to say which one's better? I think there's weak science to suggest that a lactate might be a little better predictor.
Thank you.
That's my take. If you had 20 people up here, you get 20 different opinions on that. So I'd be the first to admit that.
Thank you.
Very good. Over here on the left, sir.
Hello. So the patient that you are thinking with CNS infection like meningitis, what is the use of steroids beside antibiotics?
They appear to be out now. But is this an odd day or even day? You know?
So the question here with the steroids has been, will this, how much inflammation is happening with the meningitis? We used to think there was a higher amount of inflammation with H. flu than strep. And what you're talking about is the hearing loss and problems. And does steroids administered, ideally, before the antibiotics, this is the old thinking, prevent hearing loss in these settings? Does it make their outcomes better?
Yeah, and that was in kids, though. It wasn't
That was in
adults.
kids. And so that was sort of the argument in favor of it. And you'll still hear that bandied about.
One more question would be seizure versus pseudo-seizure. What is the use of prolactin?
Pseudo-seizures and prolactin?
Yeah, so the seizures are supposed to have higher prolactins and the pseudo-seizures aren't, right? Is that
Right.
that's the take on that? I have to admit, I haven't looked at that in quite a while. There were some papers that were out a little while ago. I don't know how useful that is. I don't have any personal experience with it, but there have been some reports suggesting that you could do that. You could probably separate them with a lactate too, or with a VBG.
Yeah. Yeah.
Thank you.
Very good. Ma'am, over the
Or, myoglobin. What about myoglobin?
I don't know. I don't know.
Go ahead, ma'am.
Question about altitude sickness. Can it occur even below 8,000 feet? I guess I have some patients who have been to lower mountains and have been sick and, of course, have been asking for acetazolamide.
Yeah, it can occur. It's when they say that 8,000, that's kind of like for all comers, but certainly it can occur below 8,000 feet. Everyone's a little bit different when it comes to this, so it's not an absolute number for sure. Go ahead.
And I would believe them. So if they tell you, so people have pretty fixed responses. So this has a lot to do with their hypoxic ventilatory response and their cardiovascular output. So if someone tells you, hey, every time I go to 6,500 feet, I get altitude sickness, I would believe them. I would believe them. It's also very interesting to look. Sometimes one of the things that gets found out in these people who have low onset symptoms with AMS, if you work them up, and I'm not saying this should trigger a workup, but it certainly ought to listen to their hearts, because sometimes they're found to have ventricular septal defects or a patent foraminal valley or something else that's impacting the way they respond to a little bit of oxygen deprivation at altitude. I think the lowest I've ever seen reported in papers on this, and I followed these pretty closely for a while, was around 5,000 feet. Yeah. So 2,000 meters is about sort of the threshold,
And
5,000 feet.
Diamox, I didn't mention, but Diamox has some pretty specific side effects because of the carbonic anhydrase activity. It can make carbonated beverages taste completely flat, and it makes things taste weird. So it's something to tell people about. It can also make your body feel kind of tingly.
You'll tingle and you'll pee a lot.
Yeah.
But the thing to remember about Diamox when people are going to significant altitude, I go to these cabins that are up at 9,700 feet, and I can't sleep there. So the statement that I like from the wilderness medicine people is there's no better sleeping pill at altitude than Diamox. And the dose that's been employed has been dropping. We used to give 250 routinely. Now they're saying 125 will do it.
I see. And do these symptoms appear as they're climbing, or do they occur a few hours later?
It depends on what their rate of climb is, right? So no, they can definitely happen as you're climbing, but the worst symptoms are after the first night of sleep. So you'll start feeling symptomatic before you go to sleep, but when you go to sleep at altitude, if you're having AMS, you're going to have a hard night sleeping, and you're not going to feel good in the morning.
Thank you.
One of the few nice things about getting older is that this is much less of a problem in the old because your brains are smaller. And it allows the room. It allows the room
for the edema.
It allows the room for the edema to exist. So I don't get it anymore. we have courses in Vail.
I still take my Diamox
year.
for Vail.
So only the young people suffer.
Over on the left, sir.
Actually, my question is related to septic joint. I had this patient 2 weeks ago, 80 years old female, that was sent by family doctor to me to rule out septic joint in the wrist specifically.
Which joint? Wrist?
Wrist joint.
Okay.
Yeah. So when I saw her, definitely it felt it was a hot joint.
Yeah.
A little bit swollen. I ordered CBC, SIDS, all these tests, and tried to aspirate that, and I couldn't get anything. So my suspicion was there for the septic joint, but then when I got back all my blood work, CBC, the neutrophils were about 10,000, not highly elevated, but ESR was elevated about 40 or 60. But with no aspiration, I couldn't get any aspiration. I called the orthopedic surgeon. He said, like, as an emerg doc, if you can't aspirate, I can't do that either. So, you know, and this is just at the end of my shift. I ordered an ultrasound, tried to get her back tomorrow morning just to make sure that I have a good follow-up with her. But her uric acid was not elevated as well. So I was left with this lady as almost at the end of my shift. I didn't know what's going on with her.
And how old was she again?
I'm sorry?
How old?
80.
80.
80 years old.
So
but afebrile.
So in an 80-year-old, the one you're really worried about in the wrist, so so gout doesn't like the wrist, but pseudo-gout loves the wrist. So this sounds like pseudo-gout to me. She's not really in the heart of the GC zone at 80. But the two things that like the wrist are so just based on the joint involved, the two things that like the wrist are GC and pseudo-gout. And sometimes on pseudo-gout, if you go back and look at those x-rays, look for some speckling calcification deposits over what's called the TFCC, the triangular fibrocartilage complex. They're often missed on the initial x-ray, but if you put it up on the PACS and you put it on MAG and zoom in on it, you'll see some I bet this is pseudo-gout. 80-year-old, wrist pain, hot joint, pseudo-gout.
Yeah, they get the calcium pyrophosphate deposited in their articular cartilages, and so in a big joint like the knee, it's much easier to see that than a wrist joint.
Go to Google, look up pseudo-gout of the TFCC, and get some images. You'll see them. But everything about this story, an 80-year-old, all the things you're saying, normal white count, all the other things, everything reeks of pseudo-gout in this story.
So what happened actually, the next day she came back, another emerg doc saw her, and he put her on an IV antibiotic, despite he thought, like, because of their range of motion, the ESR was elevated. Is that a right? Because my suspicion was more for a gout, actually. That was my suspicion.
Pretty uncommon in that age group and in that joint.
Okay, good, thanks.
I don't think, the antibiotics, we all do that at times. We're covering ourselves, they're not getting better. But I would lay odds that that's pseudo-gout.
All right, thank y'all very much.
Thanks,
Enjoy
everybody.
lunch.
Thank you.